Sundry,
Okay, yeah, go ahead, Dave.
this is Dave. I mean, I think that's really interesting that
Yeah.
it's interesting here. You can see almost 40%, despite the PPD shortage, really have not, really looks like re-examined their LTBI testing policy. Now, a lot of that may be that they've already looked at it before,
Right.
prior to the shortage, and they've already kind of, I guess, reassessed who they're screening. But I think that's pretty surprising.
Yeah, I think that's probably the case, or maybe after this webinar they're going to look at their LTBI screening policies. But interestingly enough, 60% are, and that could be the positive impact of all of this, is exactly what John Workington was saying in his presentation, that we really need to now look to see that we are targeting those at high risk for testing. And we are going to hear in our next presentation about ways in which Hawaii is doing that right now, and New York. So let's go to the next polling question. Okay, in your opinion, is there a significant amount of low-risk LTBI testing being performed in your community? This will help us address what you just brought up, Dave.
Yeah, I agree. I mean, I think, whenever there's, an impact or something that happens to a program, it's always a good thing to stop and reassess. I mean, that definitely happened with INH, and I think it's very, very important that it happens now with the skin test, the antigen shortage.
So this is interesting because it looks like there's only a 10% difference from the response to the last question, suggesting that those programs that do feel that there's a significant amount of low-risk testing being done are the ones that are addressing their policies.
And one of the things I'm seeing on the chat, and first of all, thanks for chatting, guys. It's, but one of the things you're seeing, which I think is true, is that some people are saying that some of the policies are being driven by the Department of Health in their areas, where the Department of Health may really be dealing with a different population that they're seeing in their facility. And I think that really stresses the importance that it's really, the decision to test is really based on your local, I mean local, risk and assessment.
Yeah, I think that is true, and I think that's what our guidelines say as well. So why don't we go to the next polling question? Is routine LTBI testing a requirement for students in your community?
And I think these next couple of questions are really trying to address some populations that maybe in your community may not be high risk, but yet they're still being either mandated or recommended, and that's causing a lot of stresses. And we're going to address a lot of these stresses in these different circumstances and situations, but we want to get an idea of how many different situations, and how they're differing in our participants.
And probably we could have included a question asking whether a risk assessment questionnaire is used even in these populations prior to testing.
And Dave and Sundry, some people are asking, are you talking about college students or healthcare students or public schools? Do you define that?
I think any of the above. You're 100% right, Donna. I mean, a lot of areas have for just getting into public schools or the primary schools.
Right.
They need to be tested. But again, at least in Florida, I think one of the things we're going to talk about is that these tests have their limitations, and that's why whenever you're doing screening, you always want to screen, as Sundry is saying, with a risk assessment. And you're right. I think we may have been better off if we asked the question, if we are requiring it, is it being done with a risk assessment or the requirement for a test? You're right, Sundry.
Yeah, and I think this also speaks then to John's point that you screen these people, let's say all kindergartners who start the school year, and then you end up potentially treating patients that don't need to be treated. And there is definite risk to individuals. Okay, so 50%, over 50% of the communities the people represent here, students are required to be tested. Let's go to the next question. Okay, same question except for food handlers in your community.
And here you see a difference, and I think this is a major change over the last 20 or 30 years, where many communities had requirements for food handler testing. And you see here, at least the majority seems like there is no screening, and I would take screening meaning either risk assessment or LTBI for food handlers.
Okay. Yeah, we're seeing very different results here, as we would expect, but still 11% of those in the line are responding, or those who respond to this question are stating that that there is testing requirement for these food handlers. Okay, next question. Same question, is routine LTBI testing requirement for retirement or long-term care facilities in your community?
And here you're seeing a difference again. Here you're seeing the vast majority do have that requirement, and we're going to talk about that a little more specifically after Dick and Margaret talk about their experiences and use their experiences kind of a springboard for further discussions. But I think you see here that the vast majority looks like do require it.
Right, and that's probably what we would have predicted.
And again, what's interesting, it says here LTBI testing, not risk assessment. So I wonder if, but I think I agree with them, at least in Florida. A lot of our long-term facilities do have that requirement.
PTH is correct.
Right, so let's go on to the next question. For those populations that are low risk but where LTBI screening is required, have you postponed LTBI testing due to the PPD shortage? Yes? No, we're using I-grade testing, or no?
And Sundry, here I think you're seeing here that interestingly enough, I mean it's a 50, it's very close. I mean you're seeing that almost close to 50% have in fact stopped or at least they postponed their LTBI testing, but seeing 6% that have switched over to IGR and 45% that have not postponed it.
This is really split between yes and no. Interesting. So again, I think Dick and Margaret are going to speak to this, but there's probably some legislation that's involved that drives the testing in these groups.
Without a doubt, and that's very, in some ways, somewhat, it ties a lot of our hands, that even if we wanted to postpone it, we would run into problems with regulations.
Okay, well that was really interesting, and I think we're going to turn this over now to Dr. Richard Brostrom from Hawaii to discuss what's going on in his state right now.
Good morning, can you hear me?
We can hear you, Dick, thanks.
Great. Okay, good morning. I'm still on my first cup of coffee here. But before I start, I have to warn you that both my two dogs and my two teenagers tend to bark around this time in the morning. We'll try to get through this undisturbed. In the next 10 minutes, I'd like to review our state response to the current PPD solution shortage, and we'll talk about the current status of TB screening in Hawaii, Hawaii's response to the PPD shortage, and then maybe something we'll call the silver lining. So, Honolulu, Waikiki Beach. It is beautiful, but it's crowded, and it's not crowded just on the beach. Oahu County counts as the 10th largest city in the U.S., and it is a state of immigrants. Over the last 5 years, we've had the highest TB prevalence in any state, and 9 out of 10 cases in Hawaii were born outside of the 50 U.S. states. We think of ourselves as the Ellis Island of the West, and the health department has been battling high TB rates for many years. Consequently, mass screening for TB began in earnest in the 40s. Here was a successful project to screen 1,000 people per day with chest x-rays for 20 weeks. And I'm very glad I didn't have to read all those tiny little x-rays. Those efforts, however, were largely successful with resultant drops in TB rates. A 98% drop in TB rates from the 1920s was accomplished here in Hawaii. And we're still busy screening today. But as was mentioned already, some of our screening requirements are now fairly out of step with the U.S. mainland.
Dick, I think there's some request that you speak a little louder.
Okay.
Thank you.
Is this any better?
Fine for me here. I don't know, Dave and Donna, are you hearing him fine?
We're good, Dick. Thank you very much.
Should I
Great.
march on, or do we need to go backwards?
No, march on.
Okay. So our students are certainly overscreened, as are our food handlers. 100% screening for all food handlers still exists in the state. Worse, the method for screening is hard-coded into our state law. It's TST-only country in Hawaii, and I know some of you have dealt with this as well in your states. Hawaii laws specify TST and that the cutoff is 10 millimeters. There are no exceptions. IGRAs are not allowed to substitute for the TST. Risk-based screening is not allowed, and there are no religious exemptions to TB screening that are allowed. So if a child from Montana comes over to start school in Hawaii in 3rd grade and they bring a 2-week-old IGRA, they are told that they cannot attend school until they undergo a skin test. Not surprisingly, the community, several folks have challenged the state on that, but the state has withstood several court challenges that because the law is so clear. The result is that over 1,000 skin tests are placed every week by the Hawaii Department of Health. We do more than 50,000 skin tests every year. Half of them are done in our clinic in downtown Honolulu. This slide reveals some of the results of 10 years of screening for our state program. And these screening efforts have yielded 10 to 15 new TB cases every year, around 10% of our annual caseload. And you can see that the rate of TB disease per 100,000 is actually fairly substantial. So we are aware that there is some value of all this skin testing done in Hawaii. We just need to aim it better. So now to the point. Our response to the skin test solution shortage has been mostly of recent. In December, we heard rumors, but we had no supply problems in Hawaii. In January, we ordered extra PPD solution, although we continued to have adequate stocks. In February, our state inventory was at its usual 8 to 10,000 doses, but it was very clear that the shortage was imminent, and we reported that to our administration with hopes that we could modify our screening methodologies. However, we were able to order in March another 3,000 doses of Alpasol to augment our current inventory of 5,000 doses of Tubersol. So that's about a 2-month supply, and we were told that Tubersol would be available by mid-April. And we comforted ourselves with the thought that we were going to be able to get through this without any adjustment in our current rules. In April, the state inventory dropped to 3,000 doses, and unfortunately our Alpasol order was halted due to a vendor not being compliant. It was a new vendor, and with all of the rest of the nation clamoring for a limited supply, the vendor understandably was not very interested in jumping through all of our hoops. So in addition, the date for the 50-dose vials was pushed to late May, and we got nervous at that point and decided it was time to pull the fire alarm and notify the state. So we met with the, in early April with the Attorney General, with the Municipal Disease Director, and we reviewed our options. And we came up with 5 different options. It looks like we're preparing a vote on these options, Sundari?
I don't know,
those
Donna,
ready?
did you do this
I
as
do.
voting?
Yes, I'll
Let me
pull
go
those over
through-
right now.
Okay,
Okay.
yeah, we'll have it.
I'll go through them first, and then you can pop it up there.
Okay.
So Plan A was an optimistic plan to change the state procurement rules so that we could purchase our Applesol and get us through to the end of May. We called the state procurement office, and after they finished laughing, I think, they let us know that that would take only a request from the governor to accomplish.
Dick, before you go through them, why don't we just have the vote?
Sure.
Let's do that, Donna. Okay, so before you're biased with the rest of the plans, go ahead and vote. What do we want to do? Read the plans out, because we can't read that.
So I'll read the plan. Plan B
Yeah,
is
go ahead and read them.
for the governor to declare a public health state of emergency to halt screening requirements and possibly get around the procurement rules. Plan C is to begin risk-based TB screening, which is a major change in operations, which our operations include 200 TSTs a day, and will still run out in about 6 weeks instead of 3 weeks. Plan D was a rarely used provision where the Director of Health can actually suspend an administrative rule for 16 weeks, but that can't be extended. Plan E was to ride it out, and there's a decent chance we're going to make it.
I don't think they can do C because it's...
Okay, well, let's see. We're going to hear from you what was feasible to do, but it looks like the majority of people right now would choose Plan C, which is to begin risk-based TB infection screening, which would be a major change in your operations, and you'd still run out just in double the time, 6 weeks. So that's what most people are choosing. Some, the public health state of emergency, Plan B, and another about 12% or so having an administrative rule be waived. So, okay, why don't we hear what you did?
Okay. Well, Plan C was our choice in committee, but after speaking with the Attorney General deputy, it was very clear that that was against the state law and that we weren't allowed that option, and instead opted for the next best choice, which was Plan D. The health director was able to waive state screening requirements, all TB screening requirements, for a period of 16 weeks. Under that plan, we continue to screen our TB workups, working hard not to say the word suspects anymore. Continue to screen TB contacts. We continue to screen individuals who are referred to us by all private clinics with the medical risk factors, either medical conditions or medical treatment that increase their risk of progression to active TB. And we continue to screen our immigrants referred from DGMQ, a significant number of folks that we process each day, because we find in our V1 immigrants that about 6% are truly culture positive despite in-country screening. Overall, we estimated this would be about 200 tests every week, and that would last us close to the 4-month period by which we remain hopeful that we can resume normal activities. How about the silver lining? Well, with any crisis comes some opportunity. And for our TB program, it was our first statewide effort since I arrived almost 3 years ago to reach out directly to clinicians and improve communication with our clinicians, which we think is really important. And certainly with any crisis that's ongoing, communication is the number one tool that you need to work through problems that are facing the state. But more importantly for us, we did realize this was a golden opportunity for us to accelerate the normal 3-year process of changing the state law and to allow for FDA-approved tests for TB infection beyond the skin test, to implement a risk-based screening methodology, which was briefly attempted in the 1990s. And then in 2007, Dr. Wing did her best to push it through, and we were rebuffed by members of the community, including several pediatric groups. The problem here is that we're trying to squeeze a 3-year process into 16 weeks, but we remain optimistic that now that we have the attention of our governor, the Attorney General Office, our partners, that we are beginning to plan our public hearings already for the summer to implement risk-based screening. And here's why that's really important to us, because as was mentioned earlier, the state of Hawaii overscreens low-risk individuals and undermanages, undertreats high-risk individuals. So that same screening data I showed you earlier was broken into U.S.-born and foreign-born, and it reveals all the low-risk screening that we're doing. Very sharply demarcated between the foreign-born and U.S.-born in terms of TB case rate. Particularly, you can see for students, with 126,000 students being screened and 2 cases of TB determined, whereas in the foreign-born students, nearly 50,000 screened with 50 cases. In the end, with these 3 categories of screening, we find that 95% of our active TB cases are found in 25% of the population. I remember Tom Privet at the NAR stating that placing TSTs was the New Jersey state pastime, and I think it's probably the same is true in Hawaii. Here's the same data shown graphically, and it highlights the need for risk-based screening, and I think also hints at the benefits of alternative TB infection testing methodologies that might perform better in the foreign-born population. So that brings me to the end, which is the last 2 slides and a 30-second commentary, which might be more of a rant in the end. Please bear with me. In 1920, a TB case in New York might reside at the State Hospital for TB in Raybrook. The hospital was built at an inflation-adjusted cost of $30 million and an adjusted annual state budget of $3.5 million. New York State directly funded and supported 21 other TB hospitals at the same time. TB control was a very, very expensive, high-priority, state-funded activity. That budget is it comes to nearly $100 million, which is nearing the national budget of DTBE. In 1950, treatment for TB required 2 years of public-funded inpatient hospitalization, which would now cost them more than $600,000 for every TB case. And the national TB case rate was 25 times higher in 1950 than in 1912. You can imagine the expenditures required to treat patients in 1950, although obviously not everyone was lucky enough to receive treatment at that time. But again, in 1950, TB control was a very expensive, high-priority, state-funded activity. I guess the point is that phenomenal strides in TB control that we enjoy today have never been inexpensive, and they're a direct result of large public expenditures that have brought us to the brink of TB elimination. In Hawaii, our strategies for both TB case finding and TB prevention are based on a 130-year-old diagnostic test with unacceptable specificity and a 65-year-old medication with rapidly vanishing efficacy.